can go ahead, please.
Okay. Good evening, consultants and colleagues. First, my apologies for the earlier on hitches. And then today we'll be discussing on the pharmacology of antihypertensive medications. And please, I hope I can be heard.
Yes,
Hello?
you can be heard. You can be heard.
Okay. Please, next slide there. Okay, we'll begin the discussion with the following outline: introduction, trying to understand the physiology of blood pressure regulation, epidemiology, measurement of blood pressure, terminologies in hypertension, and then pharmacology of antihypertensive medications and drugs used in hypertensive emergencies, conclusions, and then references. By way of definition, hypertension or persistently elevated blood pressure is a chronic medical condition that significantly increases the risk of cardiovascular diseases such as stroke, myocardial infarction, and heart failure. Hypertension is the central most common cardiovascular disease and an important risk factor for other cardiovascular diseases by virtue of its ability to cause endothelial dysfunction. In a National Health and Nutrition Examination survey carried out in 2011 to 2012, hypertension was found in 29% of American adults and 5% of adults aged between 75 to age 65 years and older. And the diagnosis of hypertension is based on a repeated and reproducible measurements of elevated blood pressure, which serves primarily as a prediction of consequences for the patient. However, it seldom includes a statement about the cause of the hypertension. So this definition is important for the fact that hypertension is based on the repeated and reproducible measurements of elevated blood pressure. Most books say 12 hours apart. However, it is important to know that despite the extent of elevation of the blood pressure, it does not actually tell us the cause. Now, most people can just see a patient and they get a blood pressure of 160/90 millimeters of mercury. That does not actually qualify for hypertension, except that is repeated, and then the same value or even higher values above 140/90 millimeters of mercury is reproduced upon repetition. Now, it depends on measure of blood pressure and not on symptoms reported by the patient. I think I have to use this. Chief, you are still in the same slide. Now, there's another one before this. Okay, hypertension causes endothelial dysfunction via its ability to induce vascular wall-sharing stress and resulting in platelet aggregation and end organ damage via multiple mechanisms that alter the electrophysiology in different tissues and death. Sustained arterial hypertension damages blood vessels in the kidney, the heart, and the brain, and leads to an increased incidence of renal failure, coronary artery disease, heart failure, stroke, and dementia. Starting at values of 115/75 millimeters of mercury, cardiovascular disease risk doubles with each increment of 20 millimeters of systolic and 10 millimeters of systolic blood pressure through the blood pressure range. Now, both systolic hypertension and diastolic hypertension are associated with end organ damage. And then the so-called isolated systolic hypertension is not actually benign as it may look. This may not go so fast. Then epidemiologic studies indicate that the risk of damage to the kidney, heart, and brain are directly related to the extent of the blood pressure elevation. So this goes on to say that the more a person has high blood pressure ranges, the higher the chances of having complications related to this value of blood pressure. Then every mild hypertension or blood pressure of 140-90 millimeters of mercury increases the risk of eventual end organ damage. Then antihypertensive medications are used to lower blood pressure by targeting different pathophysiological mechanisms that dysregulate vascular tone, cardiac output, and blood volume when the intrinsic neurohormonal control mechanisms fail. Chief, can you move on faster? Let me see if I can use my phone.
I think you have an internet lag. I'm already on the next slide.
Yeah, I'm trying to see if I can actually use my phone, please. Sorry. Okay, Chief, next slide, please.
Dr. Chibuke.
Yeah, I'm here.
So
I'm trying to see if I can use my phone. I think.
as in use your phone's internet or use your phone to
No,
present.
use my phone so I can share as well. But let me continue. Sorry. It's because I think there's a delay. Many effective drugs are available. Oh, sorry, there's a part I missed, please. Can you go back? Okay, yes. Now, we have said that antihypertensive medications are used to lower blood pressure by targeting different pathophysiological mechanisms that dysregulate vascular tone, cardiac output, and blood volume when the intrinsic neurohormonal control mechanisms fails. Then effective pharmacological lowering of blood pressure has been shown to prevent damage to blood vessels and to substantially reduce morbidity and mortality rates associated with hypertension. Many effective drugs are available, and knowledge of their antihypertensive mechanism and sites of action allows accurate prediction of efficacy and toxicity. So, because the blood pressure, the problem of blood pressure, there are different blood pressure control centers in the body. Now, the choice of blood pressure antihypertensive medication use actually depends on the actual points in the pathophysiological range that one actually wants to achieve. Then the rational use of antihypertensive alone or in combination can lower blood pressure within minimal risk of toxicity in most patients. Now, in a study, unfortunately, 1/2 of Americans with hypertension had inadequate blood pressure control, and hypertension usually is symptomatic until overt end organ damage is imminent or has already occurred. Some patients might come and tell you that they are having, whenever they notice that their blood pressure is high, that they have headache, they have different kinds of symptoms. But the truth is that hypertension is actually, in most cases, usually asymptomatic. And when you start having symptoms, it is actually when there is evidence of end organ damage, like headache, maybe as a result of increased intracranial pressure. Then blurring of vision may be due to vascular retinal changes, and then a lot more. An increase in blood pressure with aging does not occur in populations with low daily sodium intake. Now, there are some ongoing studies around that actually suggest that most people who were not apparently supposed to be hypertensive eventually become hypertensive when they expose themselves to early early onset of high salt intake, especially in childhood, because what happens is that the taste bud of most children gets adapted or get used to the high salt contents of food. And over time, there is a buildup of sodium, which may over time bring about the development of high blood pressure. So that is one of the mechanisms in which high salt diets can trigger hypertension or elevated blood pressure in patients who were apparently not supposed to have hypertension. And the risk and therefore the urgency of instituting therapy increases in proportion to the magnitude of blood pressure elevation. So when we see a patient with certain blood pressure ranges, it is important to understand the number of blood pressure medications that should actually ideally taper down the blood pressure to a maximum tolerable range, or as low as possible, the ALARA principle according to the ESC guideline of the 2024. Now, the risk of end organ damage at any level of blood pressure or age is greater among African Americans and relatively less in premenopausal women than in men. And then other positive risk factors, including smoking, metabolic syndrome, including obesity, dyslipidemia, and diabetes, manifestations of end organ damage at the time of diagnosis is important, and a family history of cardiovascular disease. So in the past, besides the extent of the level of blood pressure, it is also important to risk stratify patients, especially according to the recently released European Society of Cardiology guidelines. It is important that when we make a diagnosis of hypertension, the value of the hypertension is not just, the value of the blood pressure range is not just only important. It's also important to risk stratify the patient such that other risk factors, we have other traditional risk factors and then the non-traditional risk factors. The traditional risk factors such as metabolic syndrome, obesity, dyslipidemia, diabetes, then smoking, and then the non-traditional risk factors such as the history of stillbirth in women, previous history of preeclampsia, history suggestions of miscarriages, and then patients that have had patients that are mentally deprived and patients also in IDP camps. So if you have patients with this, it is important not just to look at the blood pressure value, but also to risk stratify them. Then, according to the World Health Organization, the global epidemiology of hypertension shows that an estimated 1.2 billion adults aged 30 to 79 years worldwide have hypertension, with majority, about 2/3, living in low and middle income countries. And this represents a significant public health concern, as hypertension is a major cause of premature death globally, especially in our environment where people have poor health-seeking behavior. And a large proportion of individuals with hypertension are unaware, especially in low and medium income countries, of their condition and are not adequately treated and controlled. And even those who are on medication have not achieved optimal blood pressure control. The prevalence of blood pressure hypertension around the world is about 26%, and is estimated to have about 20% of the world population is estimated to have hypertension, but the prevalence expected to increase further in developing countries. The reasons abound. One of them is income disparity. The majority of people with hypertension reside in low and middle income countries, and the health-seeking behavior is very, very minimal or discouraging for a lot of reasons. There is no comprehensive health insurance policies to take care of to minimize the out-of-pocket expenditures for health. Now, awareness and control. A large percentage of adults with hypertension are unaware that they have the condition, and even among those diagnosed, only a small proportion have their blood pressure adequately controlled for a lot of reasons. These reasons from our clinical practice stem from poor understanding of the disease process by the patient, and then poor patient education by the doctors. Now, some of us do not actually go out to tell patients that the moment they become diagnosed with hypertension, there is a high chance that they may take their blood pressure medications for life, especially if that hypertension was of a secondary cause, which in most cases usually if the underlying cause of that secondary hypertension is removed, then the patient may not have the need to take medications. Like if a patient has renal artery stenosis, less than 50%, and the patient gets a stent, the patient does not really necessarily need to be on medications. Now, the age factor, the prevalence of hypertension significantly increases with age, with a particular high rate among individuals over 60 years. There's a study that shows that if all of us, regardless, were to live out our lives, will at some point in time develop or rather become hypertensive. Now, what are the factors contributing to the global burden of hypertension? Lifestyle factors. We now have a preponderance of unhealthy diets, high in sodium, lack of physical activity, excessive alcohol use, and smoking. We have adopted a lot of foreign lifestyles. We now take a lot of junks and the rest of them. Now, genetics, we know that most families have we know that there's familial hypertension, primary hypertension, which run in families, and then socioeconomic factors, limited access to healthcare, poor health literacy, and stress, as well as mental deprivation, chronic stress, chronic stress, and then chronic depressive states can also account for the reasons why people develop hypertension. And then regional variation in prevalence. Prevalence and control of hypertension can vary significantly between different regions and countries due to diverse lifestyle factors and healthcare systems. Of course, when we compare the level of, when we compare disparity in healthcare outcomes in Western countries and most countries in Africa, we understand more about this. Now, because we have said that in understanding the basic pharmacology of blood pressure medications, it is important to understand, first of all, the physiology of blood pressure regulation. And we have said that the essence or the choice of the use of each of these antihypertensive medications is because of what we want to achieve. Is because we have come to the understand that to achieve effective blood pressure control, we have certain cycle in the physiology of blood pressure regulation that we must intercept or we must modulate so that we can actually effectively control blood pressure. Now, according to the hydraulic equation, arterial blood pressure is directly always proportional to the product of the blood flow, which is cardiac output, and the resistance to the passage of blood through the capillary arterioles, or what we call the peripheral vascular resistance. Now, physiologically, in both normal and hypertensive individuals, blood pressure is maintained by moment-to-moment regulation of cardiac output and peripheral vascular resistance. And this is exerted at three very important anatomic sites. One, the arterioles, the postcapillary venues, which are called the capacitance vessels, and then the heart. And there's a fourth component, very important part of this blood pressure regulation control, which is also the kidney, which also functions to regulate salt and water retention, as well as the intravascular volume. So it's important to understand that baroreflex is mediated by autonomic nerve, act in combination with humoral mechanisms, including the renin-angiotensin-aldosterone system, to coordinate function at these four control sites. They always work in interplay through negative feedbacks and then to maintain normal blood pressure. Now, we also know that local release of vasoactive substances from vascular endothelium may also be involved in the regulation of vascular tone or vascular resistance. For instance, endothelin-1 constrict blood vessels, while nitric oxide dilates blood vessels. Now, all antihypertensive drugs act by interfering with certain normal mechanisms of blood pressure control, either through the baroreceptor reflexes or through the renal control centers for blood pressure regulation. Now, central sympathomimetic neurons arising from the vasomotor area of the medulla are always tonically active. And carotid baroreceptors are always stimulated by a stretch of the vessel walls. So if the baroreceptors, which are found in the arc of the aorta and the bifurcation of the carotid vessels, are always stimulated depending on the stretch of the vessels, brought about by internal blood pressure dynamics, so that when the blood pressure is elevated, they are stretched by way of disinhibition, or when the blood pressure is low, they also stimulated by way of inhibition. So receptor activation inhibits the central sympathetic discharge. Conversely, reduction in stretch results in a reduction in baroreceptor activity. Now, in the case of a transition to upright posture, what happens is that baroreceptors sense the reduction in arterial blood pressure that results from pooling of blood in the veins, also known as the capacitant vessels, below the level of the heart, a reduced wall stretch, and sympathetic discharge is disinhibited. What we have explained should help us understand that. Now, this reflects increase in sympathetic outflow acts through nerve endings to increase peripheral vascular resistance, which brings about constriction of arterioles and cardiac output by direct stimulating of the heart through the increased firing from beta receptors and then constriction of capacitant vessels. Now, this increases venous return to the heart, thereby restoring normal blood pressure. So as I explained earlier, we have said that the baroreceptor, that the physiology of blood pressure regulation is controlled at 4 very important anatomic points. We have one from the heart, one from the capacitant vessels, the sympathetic nervous system, which the vasomotor center plays an important role, and then as well as the kidneys. And we have said that this dynamics in blood pressure regulation works by virtue of disinhibition when there's a fall in blood pressure, or by inhibition when the blood pressure rises, so that there's activation of the vasomotor center and then increase sympathetic overflow, which also act directly through the beta 1 receptors, both in the heart and the kidneys. And this work in synergy to either increase cardiac output through the heart and the arterioles, or on the other hand, through the beta 1 receptors in the kidneys, which are sensed by the JJ apparatus in the macular densa in the kidneys, to now cause increased renin secretion, which stimulates aldosterone release, and then increase intravascular volume via sodium and water receptor. Via sodium and water retention. So the key points about the aortic arc baroreceptor reflex is that it rapidly responds to fluctuations in blood pressure by adjusting cardiac output and vascular tone through the autonomic nervous system. We have said that the baroreceptors are situated within the walls of the aortic arc and part of the aorta where it curves upwards. Please, we have explained this part. Can you move on? Now, the fourth control center in the blood pressure regulation is the renal blood pressure control system. Now, if by chance there is a fall in usually renal blood flow or renal perfusion, what usually happens is that there is constriction of the afferent arterioles of the renal of supplying the kidneys. And what happens is that this is sensed as a reduced sodium delivery to the kidneys, with a resultant effect of increase in renin secretion, and then a lot of cascade, which involves stimulation of the renin aldosterone and renin angiotensin aldosterone system, which functions to increase sodium and water retention, and then increase in intravascular volume. Now, the renin aldosterone system functions to induce pressure natriuresis. When blood pressure increases, the kidneys automatically increase sodium excretion in the urine, helping to lower blood pressure back to normal. And then the pressure of blood flowing through the renal arteries directly influences the rate of sodium excretion as well. So this is a diagram showing what is already explained, how the kidneys act in synergy alongside the sympathetic nervous system to increase intravascular volume and then raise or reduce blood pressure. First of all, it is important to understand how to check how to accurately check for blood pressure. One is that you must try as much as possible to prepare the patients. There's usually a rest period in which patients should sit quietly for at least 5 minutes. Sometimes when patients just come, they are still agitated, they are still anxious, we just begin to check their blood pressure. What is expected is that there should be a rest period of about 5 minutes when the patient sit down quietly. And this can be a time when we used to just discuss with the patient, calm the patient down, and then before the blood pressure is checked. And then it is important to understand, although we don't usually do that for a lot of reasons, it's important to educate patients that usually that, especially when they are coming to the clinic, they should try as much as possible to avoid stimulants such as caffeine, smoking, or vigorous exercise within 30 minutes prior to the measurement or prior to the time that they come to the hospital. However, most patients actually walk long distances to the hospital. So these are actually the people that really need to be thoroughly prepped and then made to relax and rest for a period of time before their blood pressure is checked. Then when we check blood pressures, especially in the clinic, we don't usually remember to ask patients if they have emptied their bladder. So it is important to ask patients to empty their bladder before checking their blood pressure. And then cuff selection and positioning. Now, it is important to use the correct cuff size. Sometimes in clinics, too, when people wear shirts that are so tight, it is actually advocated to place the cuff directly on their clothes rather than trying to push those clothes back on their arm so that you do not induce reactive hypertension through the tightening effect of the clothes they are wearing. So it's important to place the cuff on the bare upper arm midway between the shoulder and the elbow crease, with the bottom edge about 1 inch above the elbow crease. Arm position is also very important. It's important to support the arm at the heart level with the elbow slightly flexed and the palm facing forward. Then after this comes the measurement technique. Most importantly, these days that we have oscillometric blood pressure measuring machines, the automatic blood pressure machines, we should actually always make sure that the blood pressure machine itself is FDA approved. In a nutshell or in a summary, this is a full explanation, pictorial explanation of how one should actually be. And then there's a checklist for this, which has already been mentioned in the course of trying to check blood pressure effectively for your patient. Now there are different values for different modalities for checking blood pressure. We have different definition of hypertension for office blood pressure. We have different value for home blood pressure, and we have the daytime ambulatory blood pressure. We have the 24 hours blood pressure, and then the nighttime blood pressure. The nighttime blood pressure, anything below 120/70 at night is actually regarded as blood pressure checked at night. So if we have a patient that has a blood pressure less than 120/70 at night, that's actually called elevated blood pressure rather than hypertension. But if it is greater than 120/70 millimeters of mercury at night, that is called that actually qualifies for hypertension at night, as against the office blood pressure of 140/90 millimeters of mercury or home blood pressure monitoring check of 135/85 millimeters of mercury. Next slide, please. So I decided to show this because it is important we understand preventing and treating elevated blood pressure. Now, it is recommended as part of the recent ESC guideline to maintain blood pressure drug treatment for lifelong, even beyond the age of 85 years, once it is well tolerated. However, we must understand the caveats that are peculiar to certain ages. Now, because of the benefit in reducing cardiovascular disease outcomes is uncertain in these settings, and noting that close monitoring of treatment runs is advised, BP lowering treatment should only be considered from greater than 140/90 millimeters of mercury when measured in the office among persons meeting the following criteria. If there's a pre-treatment symptomatic orthostatic hypotension, if the age is greater than 85 years, if there's clinically significant moderate to severe frailty, and or if there's limited predicted lifespan, especially if the patient have maybe some terminal illness and all that. So there are some times that when we have elderly patients above 85 years and their blood pressure is about 140/90, we place them on medications. Sometimes it's actually advised to actually watch, and then we have to also understand some caveats that if these things are present, we may actually just decide to leave the blood pressure as it is. And then in cases where the blood pressure lowering treatment is poorly tolerated and achieving a target systolic of 120 millimeters of mercury is not possible, it's recommended to target a systolic blood pressure level that is as low as reasonably achievable. That is the ALAR principle. It is not every patient that we get that we must try and work towards a treatment target of 120, 129 millimeters of mercury, or even 120, 130 millimeters of mercury. Sometimes there are patients that will do well on blood pressure values of 140/90 millimeters of mercury. So if we get this patient, especially patients who have a high chance of having orthostatic hypotension, when we go beyond this, then this is where this ALAR principle comes in. Then terminologies associated with hypertension. We understand the term white coat hypertension, in which case a patient's blood pressure will be normal at home. When it is measured at home, the blood pressure is always normal. And then the moment the patient comes to the hospital, the blood pressure is always elevated. So in this instance, this is where home blood pressure monitoring actually gives us a true value, whether to believe the office reading or to disbelieve the office reading. And we can tell that a lot of factors, especially in our settings here in Nigeria, will be responsible for that. There are most people that enter public transport before coming to the hospital. Some of them will fight with conductors. Some of them will have issues on the road. Some of them will trek to the hospital, and a lot of other factors. So these are the things we need to consider. Then there is also the mask hypertension, in which the blood pressure is always consistently elevated at the office, out of office. That is when the patient is at home or out of the hospital, the blood pressure is usually high. However, when it comes to the hospital, this does not meet the criteria to be called hypertension or elevated blood pressure. So the white spot effect, we all know, also refers to a phenomenon where the person's blood pressure, especially in a previously diagnosed hypertensive who is well controlled, whenever the person comes to the hospital, the blood pressure usually becomes elevated. Next slide, please. Now, there's a new concept called the PREVENT calculator in the United States. And the impact of this PREVENT calculation on cardiovascular risk classification and eligibility for antihypertensive drug therapy was revised in November 2024. The American Heart Association now recommends using this new predicting risk of cardiovascular disease events or PREVENT calculator, which systematically produces a lower calculated risk than the previously used 2013 combined cohort equation. In patients with hypertension, decisions about initiating antihypertensive therapy should depends upon the level of blood pressure elevation and the patient's atherosclerotic cardiovascular disease risk factor. So in this prevent calculator use, we have to consider also the blood pressure elevation, and then we also calculate the patient's chances of having an atherosclerotic event. And among those with stage 1 hypertension, one criteria to initiate drug therapy is a calculated 10-year atherosclerotic cardiovascular disease risk greater than 10%. And in a large United States cohort trial, more than half of participants were reclassified to a lower risk category using this prevent calculator. And one thing that's noticed is that if this is applied broadly across the US, an estimated 2.6 million people with hypertension would initially be managed with lifestyle changes alone. So it's important to actually understand this. Then again, as part of the 2024 ESC guidelines, it is a class 1 indication. As a class 1 indication, it is recommended that blood pressure be categorized as non-elevated blood pressure, elevated blood pressure, and hypertension to aid treatment decisions and their risk stratifications. It's just a Please, sorry about that. Please, can you go back? Then the score 2 is recommended for assessing a 10-year risk of fatal and non-fatal cardiovascular disease among individuals aged 60 to 69 years with elevated blood pressure who are not already considered at increased risk due to moderate or severe chronic kidney disease, established cardiovascular disease, hypertension-mediated organ damage such as left ventricular hypertrophy, left atrial enlargement, and all that, diabetes mellitus, or familial hypercholesterolemia. Then in acute and short-term lowering of blood pressure, one of the newest recommendations is the fact that in patients with intracerebral hemorrhage presenting with systolic blood pressure of greater than 220 millimeters of mercury, acute reduction in systolic blood pressure greater than 70 millimeters of mercury from initial levels within the first 1 hour of commencing treatment is no longer recommended, and this is actually a class 3 indication. Then there's also a concept of patient-centered care in hypertension. An informed discussion about cardiovascular disease risk and treatment benefits tailored to the needs of a patient is recommended as part of hypertension management. This is actually important because most of our patients are not well informed about, they are not actually well counseled about their hypertension. They do not know that hypertension alone can cause a lot of other health-related problems or cardiovascular events. They do not know that hypertension can cause stroke, cause heart attack, or a lot of them. So it is important that when we are managing patients, we should actually give a holistic counseling so that they understand the problem they have and also understand how they can actually play part in achieving better outcomes. Now, motivational intervention should be considered for patients with hypertension at hospitals and community health centers to assist patients in controlling their blood pressure and to enhance treatment adherence. This is actually very important. Then physician-patient well communications are effective tools that should be considered in primary care, including reporting of home blood pressure readings. This is actually a way of advocating remote monitoring, especially for patients in rural areas. Now, home blood pressure monitoring for managing hypertension by using self-monitor blood pressure is recommended to achieve better blood pressure control. Now, sometimes when people are at home and they ask other people to check their blood pressure for them, there's usually a lot of factors that can actually make them not have true blood pressure values. So it is important that individuals are encouraged to check their blood pressure themselves, either get where they can be taught to use all these machines or learn to use them themselves. There are lots of things you can learn on YouTube. Now, in the updated European Society of Cardiology guidelines for 2024, DSC has issued updated guidelines for the diagnosis and treatment of hypertension. Now, compared with the 2018 guidelines, the update aligns more closely with definitions of hypertension from other expert groups, including recommending pharmacotherapy if systolic blood pressure is greater than 140 or diastolic blood pressure greater than 90 milliliters of mercury by office measurement, or if the blood pressure is greater than 130 or diastolic blood pressure is greater than 80 millimeters, if the patient is at high risk of cardiovascular events. Now, we're able to know patients that are high risk. So these days, DSC guideline does not just ask you to look at the blood pressure elevation alone. DSC guidelines also encourages us to risk stratify patients, because if we have a woman now we have had terminologies like risk modifiers or sex related risk modifiers and sex related risk factors and all that. Now, if a woman has had a stillbirth or has had a miscarriage or has had probably like preeclampsia, her blood pressure management based on that risk stratification will actually be different from someone that just has an elevated blood pressure. And then the ESC guidelines recommend initial combination therapy and a goal of blood pressure of 120 to 129 systolic and the 79 millimeters of mercury for most patients on treatment, provided treatment is well tolerated. And then in most cases, it has also talked about the use of the ALARA principle, or the as low as possible or as low as readily tolerated principle. Then in the main discussion, we're going to start on our discussion with discussion on pharmacology of antihypertensive agent, starting first with the diuretics. We all know that diuretics work at different portions of the kidneys to regulate intravascular volume, and each of them have different sites of action in the kidneys. Please, next slide. One of the most important effects of diuretic is that they lower blood pressure by reducing blood volume and vascular resistance. This is by way of their effect on sodium and water retention. They promote sodium and water excretion, leading to decreased plasma volume and cardiac output when the need may be. Based on this, we have types of diuretics such as the thiazide diuretics, in which case you have hydrochlorothiazide and clothalidone, and this acts on the distal convoluted tubule. The major mechanism of action is that they inhibit the sodium chloride syn-porter and also decrease blood volume and systemic vascular resistance. The side effect is that, just like all diuretics, they cause hypokalemia, hyperglycemia, and then hyperuricemia. However, the recently introduced thiazide-like diuretics, indapamide, was actually introduced as a result of this side effect. And again, sorry, I forgot to add that here. Diuretics is one of those drugs that is associated with a high incidence of erectile dysfunction in patients receiving antihypertensive medication. It has also been implicated in some cases to cause glucose abnormalities and then elevation in uric acid levels, causing hyperuricemia. Then the next set of diuretics which we're going to look at are the ones we call the potassium-sparing diuretic, or popularly called the mineralocorticoid receptor antagonist. Among the class is spironolactone, and then eplerenone, amiloride, and then chanterin. The difference between spironolactone and the eplerenone is that sometimes spironolactone has androgenic effect, while eplerenone do not. And that's why we tend to observe patients on spironolactone, especially if they're on treatment for heart failure, so that the moment they begin, if a patient has gynecomastia, you may want to give eplerenone instead. They act on the collecting duct, and then, as popularly called, they are mineralocorticoid receptor antagonists, and they block aldosterone receptors, and then inhibit the sodium channels, and then they are essentially used in resistant hypertension and then heart failure. One of the major side effects that they cause hyperkalemia and gynecomastia, especially spironolactone. So here is a diagram showing the different types of diuretics, and then there are different points of action on the renal table. We have loop diuretics. First of all, we have carbonic anhydrase, which we no longer use, that acts at the proximal tubules. And then we also have the loop diuretic that inhibit the sodium or potassium chloride co-transporter in the thick ascending loop of Henle. We also have the Taza diuretics that work at the distal tubule, as well as metolazone. And then we also have the aldosterone antagonists, which are the popularly called the mineralocorticoid receptor antagonists, such as spironolactone and the rest of them, that inhibit, that competitively bind with aldosterone at its receptors. Next slide, please. Now, we also have a group of drugs that are called adrenergic blockers, which have good effect on the sympathetic nervous system, as well as the adrenergic nervous system. Now, adrenergic receptors, also known as adrenoceptor receptors, are classified as either alpha or beta receptors. And these two classes are further subdivided into alpha 1, alpha 2, beta 1, beta 2, and beta 3. Alpha 1 and alpha 2 receptors both also have 3 subtypes. Now, these receptors are all G protein coupled receptors. Now, alpha receptors are GQ coupled receptor, whereas alpha 2 receptors are G1 coupled receptors. Beta 2 and beta 3 receptors are G1 coupled receptors. All beta receptors are also GS coupled receptors. Agonist binding to the adrenergic receptors include the following cellular mechanisms by way of action. So this is a picture of the various effects of the beta and alpha receptors, in which they control blood pressure and vascular volume. Of course, we all know that the vascular smooth muscles have more of alpha 1 receptors, in which a blockade will cause some form of vasoconstriction, while you have more of beta 1 receptors in the heart and then the kidneys. Next slide, please. So the alpha receptors, their action results in such a way that phospholipase C is activated, which leads to the formation of inositol triphosphate and diacylglycerol. As a result, intracellular calcium rises, and of course in the heart, and of course in the vessels, this will cause some form of constriction. Now, alpha 2 receptors, adenylyl cyclase is usually inactivated in this, which leads to a decrease in intracellular cyclic adenosine monophosphate, CMP. And then beta 1 receptors result in adenylyl cyclase being activated and result in increased intracellular cyclic AMP. For the beta 2 receptor, the adenylyl cyclase becomes activated through the GS protein coupled receptors, and there's usually an increase in intracellular cyclic AMP. The G1 protein coupled receptors are also activated, and this will increase intracellular cyclic AMP. So for the different types of beta blockers, first, we have beta blockers that reduce cardiac output by decreasing the heart rate and contractility through beta adrenergic receptor inhibition. We have all outlined the various mechanisms of action and the receptors and the proteins through which they act. We have different types of beta blockers. We have the non-selective beta blockers, which have effects on beta 1 and beta 2 blockers, such as propranolol and nadolol. However, of course, propranolol is no longer that used in the management of hypertension. But what they do is that they decrease heart rate and cardiac output. They also cause bronchoconstriction, and then they are not, and as such, because of their non-specific mode of action, you must make sure that your patient does not have asthma when you're treating this patient. And we'll also be very careful about this when we are treating our patients with thyroid diseases. We have the cardio-selective or beta-1 blockers, such as metoprolol, atenolol, bisoprolol, which preferentially block beta-1 receptors in the heart and kidneys, and they reduce cardiac workload and myocardial oxygen demand. They also increase diastolic filling time to enhance coronary perfusion in states of tachycardia. So usually there are some states that the heart beats at very fast rate, especially when the patient has atrial fibrillation with rapid ventricular rate. And what this happens is that there is reduction in the diastolic filling time, such that there is less time for the coronary arteries to perfuse the heart. And there are lots of attendant consequences because of this. This is what usually there may be some form of ischemia, and then over time you have this is how when this happens, the summary is that there is both poor blood supply and oxygen supply to the heart, and the heart may actually undergo some ischemic processes in this instance. And this also has pathophysiologic role in transition from left ventricular hypertrophy to dilated cardiac conditions. Then you also have beta blockers with vasodilatory properties, such as carvedilol, labetalol, and nebivolol. Carvedilol and labetalol block both alpha and beta receptors, causing vasodilation. Now, in instances where we want to achieve a good rate control and then also have good effect on blood pressure, carvedilol finds good use over the beta-specific blockers, which act primarily on the heart. And then nebivolol also increases nitric oxide availability. This is why most people prefer it in giving nebivolol in men, because the release of nitric oxide also helped with patients with erectile dysfunction. One of the side effects is that it also causes bradycardia, fatigue, depression, and then sexual dysfunction. So this is the whole summary of beta blocker therapy and its effect on erectile dysfunction. It can happen through their central effects of causing depression and sleepiness. It can also happen through hemodynamic effect, in which there is inhibition of inotropism and chronotropism. It can also happen through endocrinological effect, in which there is reduction in testosterone levels, or peripheral effect, in which there is some form of negative effect on vascular smooth muscle cells. Please, next slide. There are also some beta blockers that have intrinsic sympathomimetic activity, which are called either ISA or BISA. BISA means beta blockers with intrinsic sympathomimetic activity. And these include acebutolol, pindolol, oxypronolol, pembutolol, and labetalol. The advantage of these drugs is that they partially activate the beta receptor while also blocking it, meaning that they can cause a slightly lower degree of heart rate reduction compared to other beta blockers without this property. And the mechanism is that they act as special agonists at the beta receptor, meaning they can stimulate the receptor to a small degree while also blocking its full activation by other substances like adrenaline. So the advantage of these drugs is that they have a lesser chance of causing bradycardia. The implication is that due to their partial agonic activity, they are less likely to cause excessive bradycardia or slowing of heart rate compared to other beta blockers without intrinsic sympathomimetic activity. And potential limitation is that they might be less effective in situations requiring strong beta blockade, like rapid heart rhythms. We also have the alpha adrenergic blockers, which reduce vascular resistance by blocking alpha-1 receptors in blood vessels. Examples are prazosin, doxazosin, and terazosin. Of course, we found the doxazosin in good use, especially in patients with benign prostatic hyperplasia, and they are very useful for resistant hypertension and BPH. One of the side effects is that they have a high chance of causing orthostatic hypertension, nasal congestion, dizziness, or reflex tachycardia. We also have the centrally acting drugs, and these drugs lower sympathetic outflow from the central nervous system. Examples are clonidine and methyldopa. Of course, we use methyldopa more in pregnant women. The benefits is that they stimulate alpha-2 adrenergic receptors in the brainstem, resulting in decrease in sympathetic tone and lowering of blood pressure. They are used especially in hypertension in pregnancy and then in resistant hypertension. The side effect is that they cause sedation, dry mouth, and rebound hypertension if stopped suddenly. We also have the drugs that are called renin angiotensin aldosterone system inhibitors. This drug comprises of different drug classes, such as the ACE inhibitors, such as lisinopril, enalapril, ramipril, captopril. They inhibit the angiotensin converting enzyme, which is one of the most potent vasoconstrictor, preventing conversion of angiotensin 1 to angiotensin 2. And we know the effect of angiotensinogen on salt and water retention. Then decrease vasoconstriction and aldosterone release as well. They increase bradykinin levels, leading to vasodilation, but also causing cough as a side effect. And their side effect is dry cough. They also have a chance of causing hyperkalemia and then angioedema, as well as hypotension. Now, the ARBs, I'm sure they were produced to minimize the side effects of the ACE inhibitors, because they have lesser chance of angioedema and then dry cough. They include drugs like losartan, valsartan, irbesartan, and candesartan. They block angiotensin 2 receptors, the angiotensin 1 receptor subtype, reduce vasoconstriction and aldosterone secretion, and the advantage is that they have no effect on bradykinin, and then as such, they do not cause cough. Again, they cause hyperkalemia as a side effect, hypotension, lesser effects of angioedema than the ACE inhibitors. We also have the direct renin inhibitors, such as aliskiren, which is not usually commonly used here. And what it does is that it inhibits renin, preventing the formation of angiotensin 1, first of all. It is used in patients intolerant to ACE inhibitors and ARBs. And its side effect is hyperkalemia, hypotension, and diarrhea. We also have drug classes, which is called the calcium channel blockers. In our environment here, if there's no ECG evidence of hypertension-mediated organ damage, it is advised that hypertension should be the first drug line of use for treating hypertension among Blacks, because I think there's this explanation that ACE inhibitors do not really have much effect on Blacks as such. So calcium channel blockers lower blood pressure by inhibiting calcium influx into the vascular smooth muscle and cardiac cells, thereby reducing vascular resistance and myocardial contractility. We have the types of calcium channel blockers, such as the dihydropyridines and the non-dihydropyridine group of calcium channel blockers. The dihydropyridines, such as amlodipine, Nifedipine and felodipine act mainly on vascular smooth muscle, resulting in vasodilation. They are used in essential hypertension as well as in angina. Side effects is that they could cause drug-induced peripheral edema, headache, and then reflex tachycardia as well. In non-dihydropyridine group of calcium channel blockers such as rapamycin and diuretic also act on the heart and blood vessels. They reduce heart rate, myocardial contractility, and conduction, which are very useful in arrhythmias. However, one of the side effects is bradycardia, constipation, and then they can also cause heart block, especially when used in synergy with beta blockers. We also have drugs that are called the direct vasodilators. These drugs directly relax smooth muscles and then leading to vasodilation. Examples include hydralazine and minoxidil, which is actually rarely used around here. And then hydralazine is also people are no longer using it that much because of the effect on reflex tachycardia and all that. However, using hydralazine to treat hypertension here, I think there's a particular study that advises that we use hydralazine in conjunction with azoxystrobin dinitrate. One of the mechanisms of action is that they open potassium channels in smooth muscles, resulting in hyperpolarization and subsequent vasodilatation. They are used in severe hypertension, hypertensive emergencies, and heart failure. The side effects, like I've mentioned, is reflex tachycardia, fluid retention as well, and then lupus-like syndrome, which is common to hydralazine, and then hirsutism from minoxidil. Now, there are choices of blood pressure medications in some special consideration. For instance, if a patient is diabetic, you would want to prefer to start the person on ACE inhibitors and then angiotensin receptor blockers. And then as much as possible, one may want to avoid beta blockers because this may mask hypoglycemia and reduce and cause what is known as hypoglycemic unawareness. In chronic kidney disease, because of the tubuloinflammatory inflammation occurring in the kidneys, inhibitors and ARBs are usually preferred as first line, and then we try as much as possible to avoid NSAIDs and then loop diuretics, especially in advanced CKD, because in advanced CKD, patients usually have what is called diuretic resistance, and again, loop diuretics may also cause acute interstitial nephritis in the kidneys. Then in heart failure, we usually prefer inhibitors, ARBs, beta blockers, and then MRAs. And of course, the non-dihydropyridine group of calcium channel blockers, and then nifedipine as well, may not really be a good choice in patients with heart failure. Then in pregnancy too, there's a preference for methyl-dopa, labetalol, and nifedipine, and caution or avoidance of ACE inhibitors, ARBs, and then renal inhibitors. And then for African descent, calcium channel blockers and diuretics. And then it is said in some studies that ACE inhibitors may actually not be wonderful monotherapeutic agents for African patients. Now, drugs used in hypertensive emergencies. Most importantly, hypertensive emergencies are critical situations characterized by a severe elevation in blood pressure, accompanied by acute target organ damage such as encephalopathy, myocardial ischemia, or renal failure. Immediate management involves the administration of intravenous antihypertensive agents to promptly reduce blood pressure and mitigate further organ damage. The choice of medication is tailored to the specific clinical scenario, considering the pharmacological properties of each drug at the underlying pathophysiology. In defining hypertensive emergency, there are some new changes in terminologies and the description of different antihypertensive emergencies and thereabout. The 2024 American Heart Association scientific treatment maintains the 2017 American College of Cardiology American Heart Association guideline definition of elevated blood pressure as a systolic blood pressure of at least 130 millimeters of mercury or a solid blood pressure of at least 80 millimeters of mercury. However, There are changes in terminologies to be more objective and to avoid unnecessary antihypertensive therapy, included in the following. Besides, besides other terminologies, we have the asymptomatic. We now have new terminologies such as the asymptomatic elevated blood pressure, which are blood pressures of greater than 130 millimeter, 80 millimeters of mercury in the absence of evidence of new or worsening target organ damage. We also have the term hypertensive emergency, which may reflect blood pressure greater than 180, 110 to 120 with evidence of new or worsening target organ damage. Now, our hypertensive urgency, which we used to know before, has been changed to asymptomatic markedly elevated blood pressure, in the sense that the blood pressure may be elevated, markedly elevated, but it does not have any symptom. So, sorry, please. In the sense that it is actually elevated, but there is no evidence or new onset of worsening organ damage. Then the markedly elevated blood pressure now replaces the hypertensive crisis, in which case there is markedly elevated blood pressure with or without new onset or worsening target organ damage. And now the potential exists. We need to understand that the potential exists for BP-related target organ damage even when the BP is below 180, 110 millimeters of mercury threshold in specific settings, and we need to watch out for that. So it is important to actually thoroughly evaluate a patient before you can label that patient as having asymptomatic markedly elevated blood pressure. So the selection of antihypertensive therapy in hypertensive emergency should be individualized, taking into account the specific clinical context, the pharmacodynamic and pharmacokinetics of the medications, and the presence of any contraindications. Now, continuous monitoring of blood pressure and end organ function is important and essential to guide therapy and ensure patient safety. One of the commonly used intravenous antihypertensive agents for hypertensive emergencies is sodium nitroprusside. It is a potent vasodilator that acts on both arterioles and venues, leading to a rapid decrease in systemic vascular resistance and blood pressure. And it is often used in various hypertensive emergencies due to its immediate onset of action. However, it has a short half-life. However, prolonged use can lead to cyanide toxicity, necessitating careful monitoring. So, if you have a patient requiring sodium nitroprusside, it may actually be necessary to monitor this patient in the intensive care unit. Another drug that is used as an agent for management of hypertensive emergencies is labetalol, which is a combined alpha-1 and non-selective beta adrenergic blocker, and reduces blood pressure by decreasing systemic vascular resistance and heart rate at the same time. It is particularly useful in hypertensive emergency associated with pregnancy, eclampsia or preeclampsia, and situations where increased sympathetic activity is a concern. We also have nicardipine, which is a dihydropyridine group of calcium channel blocker that causes arteriolar vasodilation, effectively lowering blood pressure. It is suitable for most hypertensive emergencies, including those involving neurologic complications, due to its favorable cerebral vasodilatory properties. We also have the use of esmolol, which is a short-acting beta-1 selective adrenergic blocker that decreases heart rate and myocardial contractility, leading to reduced cardiac output and blood pressure. It is ideal for situations where rapid titration is necessary, such as in aortic dissection or perioperative hypertension. We've talked about hydrolysis, which is direct arteriolar vasodilator that lowers blood pressure by decreasing systemic vascular resistance. It's often used in hypertensive emergencies during pregnancy, but may cause reflex tachycardia and is less predictable in its blood pressure lowering effects. Now, there are selected situations in which you may want to use some specific agent used in hypertensive emergencies. For aortic dissection, there's usually a rapid blood pressure reduction is usually crucial, and a combination of beta blockers such as esmolol to reduce heart rate and vasodilators such as sodium nitroprusside is often employed to achieve target blood pressure levels promptly, especially in type A aortic dissection. Now, in acute coronary syndrome, agents like nitroglycerin, which provide both preload and afterload reduction, are preferred to decrease myocardial oxygen demand. Beta blockers such as labetalol may also be used cautiously in this instance. In situations of acute pulmonary edema, vasodilators such as nitroglycerin are beneficial to reduce preload and elevate pulmonary congestion. Diuretics such as low diuretics may also be co-administered to manage this fluid overload and then increase pulmonary compliance. For eclampsia and preeclampsia, we have said that labetalol and hydralazine are commonly used due to their safety profiles in pregnancy. And then magnesium sulfate may also be admitted to prevent seizures. And then you also have acute sympathetic crises, such as in pheochromocytoma and cocaine toxicity. Phenethylamine, which is an alpha-adrenergic blocker, is preferred to counteract excessive catecholamine effect. And beta blockers should be used cautiously and only after adequate alpha blockade to avoid unopposed alpha-adrenergic stimulation. In conclusion, hypertension, high blood pressure is a major public health concern that can lead to serious complications. It is a major risk factor of virtually every cardiovascular disease, and addressing it early is key in reducing its effect on mortality and morbidity. Antihypertensive medications act through different mechanisms to lower blood pressure and reduce cardiovascular risk. The choice of drug depends on individual patient factors, comorbidities, and potential side effects. Then combination therapy is often necessary for optimal blood pressure control in most instances. Thank you very much for your time.
Thank you very much, Dr. Ozo, for the presentation. You gave us a revision of the pathophysiology of hypertension and the control, but it was very essential to have that as a basis for the use of the medications. And I believe that made the understanding of the use of the medications easier because you've really exhausted the pathophysiology of hypertension with respect to all modalities. At this point, we call for contributions from colleagues on the call, fellows going for the exam split questions on hypertension that you want to clarify, contributions before we go to our consultants and fellows on the call. So just as a brief comment, the hydralazine combined with isosubide was used in the management of heart failure with reduced ejection fraction, either as an adjunct for those who are still not optimized and still symptomatic with EF of less than 35% as an addition, or for those who are not tolerating ACE inhibitors or ARBs, you can use the hydralazine combined with isosubide as a replacement for heart failure with reduced ejection fraction, mostly in Blacks. The study was in African Americans. So that is one comment I want to add now. Any other comments from our colleagues? Contributions, please. Any contributions? Dr. Corey, Chineme, Dr. Samoa, Felix. Any questions? Dr. Kidara. Okay, so it appears either you confused us or gave us a lot of understanding that we don't see the need to ask any questions. So I think it's more of the latter. At this point, any contributions from consultants and fellows on the call? Okay. Dr. Ojo, Dr. Ayodeji. Okay. Thank you very much once again. We go to the next session.
Good evening.
Good evening.
Yes, I don't know if I'm audible.
Yes, please, you are audible.
Yes, I just want to thank the presenter for a job well done. It's a very long one. Just want to um, some area of emphasis, especially for MCQ purpose. For example, if you have a question like which of the antihypertensive will give to a sexually active man, what will be your answer? So that's one. Then those ones that work on intestinal microbiome. So I think I've also seen that in the past question before. So we should also pay close attention to that. So those two, those ones that you can give to someone that is sexually active and that will not affect the sexual drive, that will even maybe potentiates, and the one that work by that is inhibited by the intestinal microbiome. So I don't know if you really can answer those two questions. Thank you.
Chief, sorry, you're asking the antihypertensives that are inhibited by my intestinal micro.
Yes, that I walk through intestinal microbiome.
Okay, I'm sorry, I didn't come around that.
Okay. What of the other one? The one for the sexually active man that will
Okay,
rather.
okay, the ones for a sexually active man, I think I've said that among the antihypertensive medications, the diuretics have been shown to cause erectile dysfunction. And then for a sexually active man, and then the centrally acting drugs are also implicated in that. And then some of the beta blockers, although of course there are some beta blockers that we use essentially to for blood pressure control. Now among the beta blockers, I have said that nevidolol, which releases nitric oxide, some people use it for sexually active men over the others because of this good effect in releasing nitric oxide and as it enhances sexual activity. Now, the drugs like the calcium channel blockers, especially amlodipine, the ACE inhibitors, they have lesser effect on erectile dysfunction. And in one of the studies that Professor Oji partook in, I think it is the Three Nations study or so, I can't remember. He also mentioned that a lot of patients on amlodipine and ACE inhibitors, ARBs, may complain of maybe their reduction or sexual drive and all that. It is important to also ask around other factors rather than those drugs, because these drugs have a lesser chance of affecting their sexual activity. So it is important to find out if that patient has any other thing making the person depressed, if that person has any other maybe psychological disturbances, if the person is stressed, or if the person has any challenge at all that may also coexist or be a coincidence with the time this person is taking this medication, so that the person may attribute this loss of sexual function to the medications used. So for a sexually active man, the calcium channel blockers, especially amlodipine, these inhibitors and ARBs have been shown to have lesser effect on or better for sexually active men.
Yes, you are correct. So this inhibitor ARB, yes. So that's the answer. It also does not affect spermatogenesis. So it's a very good option for especially active man with reproductive age group. Then the got microphone that I mentioned, just check. It's omesatan. there's an interaction between olmesartan and the gut microbiome in terms of reducing intestinal absorption. Most of those ARB also ask, but I think olmesartan asks more in that aspect. Then we should also not forget the effect of losartan on uric acid lowering. Be an added advantage apart from its anti-hypertensive properties. It also has its uricosilic properties, and I think that there's another ARB that has that, but I think losartan is high in that regard. So, thank you.
Sorry, Dr. Ojo, I didn't hear what you said about the olmesartan.
You said?
I did not hear what you said about the olmesartan.
Olmesartan.
I didn't hear what you said. I wasn't hearing you.
I mean interaction with gut microbiome. There's a question like that which of the ARB has a higher interaction with gut microbiome. The answer is olmesartan. So that was the point I was trying to say with that.
Hello. Good evening, Dr. Ojo.
Good evening, Chief.
Sorry, if it interacts with gut microbiome, what will now be the effect? Sorry,
So
with the interaction with the gut microbiome, what will now be the effect? Is it that the potency of the drug will be reduced or is exaggerated?
It will not be the effect on the potency. It's about absorption. You know, most of these drugs are taken orally, and you know when you are comparing their absorption, intestinal absorption. So that is what that. So if I still see the material, I will see an.
Okay, thank you very much.
Thank you very much. So I think the issue about erectile dysfunction is very important. It can become more of something that can come up for discussion. So I think we should all look at that. But just to add to that, erectile dysfunction, like the Dr. Ozo mentioned, may be vasculogenic or not. So we should not be quick to blame the medications, but a thorough evaluation is needed. And also erectile dysfunction can actually precede a coronary artery disease or an acute myocardial infarction by 5 to 10 years. So there's data to show that erectile dysfunction actually is a prognostic sign for myocardial infarction. So let's look at that. When you have a patient complaining about that, then we have to look into that and determine whether it's vasculogenic or not. And it's because there's pudendal artery stenting for vasculogenic erectile dysfunction, and they can have significant disease in the vessels. So we should always look at that. Thank you very much. So we go to the second part. Dr. Charles Okoro moderate the MCQs. We encourage
Eugene, there's a hand up. Dr.
sorry.
Adedeji's hand is up.
Dr. Adedeji. Yeah, please go ahead. Sorry.
Yeah, good evening. Thanks for the presentation. I wanted to ask him his take on when you have a compelling indication to use a beta blocker in heart blocks. Which one can we confidently use?
If you want to use
compelling indication for beta blockers in heart blocks, which one can we conveniently use as an option in settings of heart block?
I think in settings of heart block,
yes,
I think that will be depending on the degree of the heart block, won't it?
Yes, but the one with intrinsic activities have been shown to be relatively safe. At least if you have maybe first or maybe two, the movie type 1.
Yeah, that's the acetabutalol and the rest of them.
Yes, those are the ones that you can relatively use in that setting.
Okay.
Thank you, sir.
Thank you very much. Any other? So quickly, we'll go to the MCQs. We're informed by my colleague Charles. We have, I think, 2 sets of questions to quickly finish for the 3rd set. Then we go to the 4th set as we posted. Thank you. So Charles will take over.
All right. Good evening, everybody. So I'll show the MCQs. We have Dr. Philomena and Dr. Jimo. I don't know if Dr. Jimo is on the call. That's all we have from the last set so that we can finish it.